All right, you guys, let's talk about burns. This is for our CBC 231. If you have the unique opportunity to take care of a patient with burns, you can really appreciate how bad these can go quite quickly. And so let's just get right on into it. We're going to go with our objectives. We're going to discuss the pathophysiology of major and minor burn injuries. We're going to estimate wound depth and extent using the rule of nines and the Lund-Browder burn assessment chart. And we're going to assess fluid resuscitation needs of a major burn injury utilizing the Parkland formula. We'll be asking you guys to do this on quiz and a final. And then we're going to discuss the nutritional needs of the burn patient. And finally, we're going to discuss nursing interventions for that acute burn patient. So we should be considering mechanism of injury, just like always when we talk about our burn classifications. So we have our thermal burns. These are our hot objects, our steam, smoke, or flash type burns. There's also a classification of a scald burn, and that results from a wet substance such as water or hot oil, something like that. The severity of these burns depends on the substance temperature and the length of exposure. Then we have our chemical burns, and I wrote in here alkalis are actually worse than acids, and I'll tell you about why here in just a minute. But our acid burns, such as our hydrofluoric acid, carbonic acid, and white phosphorus, these cause coagulation necrosis, and we don't go quite as deep with these, but our alkalis, such as our anhydrous ammonia, our cement, our hydrocarbons, and our tar, these dissolve protein and collagen, and this really wreaks havoc on the tissue and causes some deep tissue destruction. Next, we have our electrical burns, and within this, we do have a lightning strike is included. So lightning strike is completely DC or direct current, and then we have our electrical current type burns, which are AC or DC. And we think of DC or direct current as something that is found in like a battery, solar panels, fuel cells. Think those large equipment, large construction sites, things like that. And then we have our AC or alternating current, and that's found commonly in our houses, businesses, medical devices, electronics, etc. Next, we have our radiation type burns. These can occur from sunburn, cancer radiation, or even from nuclear devices or big old nuclear incidences. And concurrent injuries of all of these can include our inhalation injuries and even respiratory failure and death. So this can happen quite quickly here. Let's think about the skin as an organ. Skin is the largest organ of our body, and it carries with it a whole lot of important properties. One is thermoregulation, not keeping us too hot or too cold. The other one is prevention of fluid loss via evaporation and barrier against infection. This is huge. Whenever we have a break in our barrier, we have the opportunity to introduce infection. So we need to be very aware of that when we're treating the burn too. And then it provides protection against environmental provided by sensory information. For instance, if we touch something that is too hot, our fingers tell our brains, right? And our brain responds by reflexing that back. So it's important to provide our sensory information there. Classification, burns are classified by depth, type, and extent of injury, not degrees as in years past. Having said that, I actually added a slide here that shows degrees, which tells you how often degrees still get used there, but we are moving away from that, and we are going to type in extent of injury, so I'll let you know about that in the next few slides here. Every aspect of burn treatment depends on assessment of the depth and the extent. And these may increase over time, which is why it's very important for even our minor burns to get reevaluated in a timely fashion, because they can increase in severity over time. Okay, so varying degrees of burn here. I wanted to show you this, one, because it shows what kind of dermal layers are involved in each of the burns, but I also wanted to show you what used to be called such and such degree is now called this extent, right? So let's move on from there. So our epidural, or AKA our superficial burns, were once called second degree. And the skin involvement here is our epidermis. I'll tell you a little bit about the signs and sensation as we move along, but these will heal spontaneously, usually within about 7 days, and typically there's no scarring involved. Now, what was once called second degree burns is now in 2 categories: one superficial partial thickness burn and one deep partial thickness burn. And this involves varying levels of the epidermal layer there. And I will get into signs and sensation with that, but basically our superficial partial thickness burns will heal spontaneously within about 14 days, and low to moderate risk of some scarring there. Our deep partial thickness burns will heal spontaneously, or they may need surgery. Usually within 21 days they will heal, and there's a moderate risk of some good sized scarring there. Our full thickness burns, which were once called our third degree burns, are involve our epidermis and then the entire dermis there. And this patient will need surgery. There's no healing capacity, no oxygen rich blood is going to perfuse and help us out with any kind of healing. And they will not heal spontaneously, and they will no doubt leave a scar. Our fourth degree burns, we'll get into those here too, but once again, no healing unless they have some surgical intervention there. Now we have our zones of injury within the burn. Our zone of coagulation is going to be this part that's shown in red. We'll talk about that a little bit more on this slide, or with the red arrow. Our zone of stasis is going to be shown in this yellow area, and then we have our zone of hyperemia, which is shown with the green arrow. Our zone of coagulation, that's going to be our most severely damaged. Kind of think of it as the epicenter of the burn there. And debridement in this case is going to be required for healing, as well as potentially skin grafting. And within our zone of stasis, this is where moderate damage occurs, and it results in decreased perfusion and edema, and because of this, there's some likelihood that we are going to need some debridement kind of help for that too. So we need to make sure that we are able to perfuse that area so we can have some spontaneous healing. Then we have our zone of hyperemia. This is that outermost area of the burn, and because of the inflammatory response, there's increased blood flow to the area, and that results in the best chance of healing if an infection is not present. If an infection is present, then boy, all bets are off. Okay, so here's our superficial burn. In our superficial burn, this involves only that epidermis, signs of this, the skin may be dry, red, pink, and the tissue will blanch with pressure. So if you put some pressure on it, turn white, right? And then we'll go right back to that area, pink or red. The tissue is erythematous and often painful. Think sunburn here. They're pretty painful. It involves minimal tissue damage, and there is no blisters associated with this. As far as our superficial partial thickness burns, we have blistering, and that blistering can be quite painful. So the patient's going to complain of a lot of pain. This is red, pink, and as you can see, it's moist. It's got this weeping serous exudate. And this also blanches with pressure, but I doubt the patient will let you try too hard or too much there. There will be some edema and decreased blood flow in tissues that can actually convert to a full thickness burn. So we need to keep a real close eye on these to make sure that they are perfusing well enough to let the body heal that area. Then we have our deep partial thickness burns. The patient will have blisterings. It will appear wet or waxy dry. And this is a great example of this picture of that. So you see that waxy dry area or even a little bit of wetness. And the skin itself may be red or pale. And then in this case, it does not blanch with any kind of pressure. In our full thickness burns, we have this waxy white or leathery gray or charred and black. You may see varying different kind of colors with this. And obviously, as we go deeper in, there's not going to be any blanching with that pressure. The area is going to be dry, it's going to be firm, and because more of the dermal layers are affected, there's not going to be any kind of hair. Our full thickness or our fourth degree burn, this is the same as our, let's see here, if we can go back to this chart here. This is the same as the full thickness burn, but a fourth degree burn includes an extension into the fascia or muscle there. And here it is. I'm using our not latest terminology, but basically this is a slide that shows you that the higher percent of body surface area that's involved with a burn, the higher risk the patient has for mortality. And the burn extent is calculated only on individuals with second and third degree burns or our full or partial thickness burns there, instead of just our superficial burns. So we don't classify how much of the body percentage is. We don't calculate the body percentage, total body surface area percentage on these guys. One way to do this is using the Palmer surface, calculating body surface area or the burn surface area. If you use the patient's own palm, you can kind of see what 1% body surface area looks like, burn surface area. Okay, so we go back to our A's, B's, and C's of treating this patient. Airway and patency and ventilation is going to be extremely important. So in addition to external injury of the skin, burn trauma can result in internal injuries. With an inhalation burn injury, the airway can easily and quickly become obstructed from edema in the airways. A hoarse voice, burns around the mouth, blistering of the oral mucosa or stridor can be an indication of burns to the airway. You might also see some soot in the mouth, and we don't hesitate to intubate these patients quickly. Hypoxia and asphyxia may result from being in a small or close space where the oxygen is being consumed by that fire, right? So that's one of the highlights of a fire, is when oxygen consumption happens and then all of a sudden we do not have enough oxygen for ourselves. So carbon monoxide poisoning can be a result of this. This can develop with exposure to fire and smoke. Carbon monoxide is colorless, odorless, tasteless, and it releases into the air during a fire. And when you breathe it in, it attaches and replaces the oxygen on the hemoglobin molecule, and that results in the carboxyhemoglobin and reducing the oxygen content of the blood. The patient may initially complain of headache and nausea and have some confusion, and then later on have an altered level of consciousness, coma, or death there. And the image that you are seeing right now is a burn patient with a risk for airway burn. Undoubtedly, lots of edema going on here. So pulmonary injury results when the products of combustion, such as smoke toxins, carbon particles, noxious fumes are inhaled into the lungs. These substances damage the lungs in two different ways. One is through the obstruction of the airway from debris, mucus produced to excrete the toxins, and dead and damaged cells. The other is cellular permeability, which causes fluid shifts, edema, loss of surfactant, and results in alveolar collapse. And these two components together result in acute respiratory distress syndrome, or ARDS, which you guys are very well aware of. One other thing to consider in pathophysiology is a capillary leak syndrome. This is very, very, very common. So the inflammatory response happens both locally at the burn site and systemically. This results in a fluid shift from intravascular space into the interstitial space. So the patient has this third spacing going on. As the tissue burns, the mediators are released. What are these mediators? Histamine, serotonin, bradykinin, prostaglandins, blood products minus whole blood, complement components, and kinins. This increases vascular permeability of the capillary membrane and will cause this capillary leak syndrome. This most commonly occurs in burns that are greater than 20%. The phenomenon of capillary leak syndrome can last for 6 to 12 hours post-burn, and almost half the fluid that you infuse during a resuscitation can seep from the veins into the tissue. So we are concerned about the intravascular space, maintaining that so a patient has adequate perfusion, right? But we know that this is going to cause great amounts of interstitial or third spacing there. Quite a significant deal. You'll see lots and lots and lots of edema initially with these burn victims, and we cause a great deal of it because we're providing them with fluid, but they need it. So just like I said, most common in burns, greater than 20%. Inflammatory response can result in release of numerous substrates, which can lead to further edema or even cardiac collapse. One other pathophysiology of a burn we need to be aware of is the mechanical obstruction. This is a circumferential burn to the chest, and circumferential burns can happen in our extremities too. So these eschars, what happens is nice and tight, and it can reduce the ability of the patient to take a full breath. So the doctor, provider has to make these relief cuts in there to allow the lung to expand there. This happens with circumferential burns, and we should really, really anticipate that an eschar-otomy or this relief cuts are going to happen if there's cool extremity, if there's weak pulses, if there's decreased capillary refill, and if there's decreased pain. There's also an indication of eschar-otomy if the patient has difficulty ventilating in that chest burn there. And then another pathophysiology of a burn is loss of skin integrity, right? And we went over these zones of coagulation and their potential for repair there, but we need to know that the loss of skin layer results in loss of vital functions, including thermoregulation and protection against infection and insensible fluid loss. Another thing we need to consider with our pathophysiology of the burn is loss of temperature control. And we need to really, really make sure that the patient does not become hypothermic, because all of a sudden we've lost this large organ, our skin, parts of it, and we're unable to thermoregulate. And this room temperature environment is colder than body temperature, so they are at a huge risk for hypothermia. This can cause coagulability issues, clotting, and bleeding disorders like DIC, which we'll talk about more in the following week. So as far as our A's, B's, and C's go with these burns, we need to consider this early intubation, especially if there's signs of inhalation injury, like singed nasal or other facial hair, burns around the nose and mouth, blistering in the oral mucosa. These are really, really good indicators that we have a future edema problems at hand. We're going to help them breathe by providing adequate ventilation, and we may have to consider an escherotomy for the mechanical obstruction so they're able to breathe. And then finally, we might have to consider a hyperbaric oxygen chamber for the patient with carbon monoxide poisoning. This allows for 100% of oxygen with a lot of pressure into it, which kind of overruns that carbon monoxide that's sent in there on the binding site there. We're going to provide the C's of the A's, B's, and C's, which is circulation and control of hemorrhage. We're going to use adult fluid replacement guidelines for anybody that's over 14 years old, and these are as follows. If the burn is greater than 15 or 20%, usually 20%, depends on what your policy says, of the total body surface area, then you are going to replace them with fluids. And what you're going to do is use 2 milliliters per kg of Ringer's lactate solution per percentage of total body surface area burned. So 2 mils per kg per percent. So this is the calculation down below. It says weight in kilograms times percent total percent of total body surface area times 2 milliliters. So half is given in the first 8 hours from the time of the burn, not the time that they show up to the emergency department. That's important to know. And the remaining half is given over the next 16 hours. So the first 8 hours, they'll get half. The last 16 hours of a 24-hour window, they're going to get the other half. We're going to maintain the adult urinary output at 0.5 milliliters per kilogram per hour, or about 30 to 50 milliliters per hour, and we might have to adjust fluids based on that. Now the pediatric is a little bit different. If you're younger than 14 years or weigh less than 40 kilograms, then you're going to be giving 3 milliliters per kilogram per percentage of total body surface area burned. And we have a lower tolerance for urine output for these patients, our pediatric patients, that we are going to have an expectation of them having 1 milliliter per kg per hour of urine back. And this will kind of really give us a great effort of hydration status, as well as how our kidneys are functioning. Another consideration for our pediatrics are going to be to add glucose or maintenance fluid, so that you might have dextrose within that maintenance fluid for the pediatric patient, and that's because they have a little bit less of an easier time of controlling that their sugar there during these burns, and can become quite hypoglycemic quite quick. In exposure and environmental control, what we're going to want to do for these burns is stop the burning process. This usually involves removing clothing and jewelry. Metal jewelry can get hot and continue on with the burning process, so we need to get rid of that jewelry. Then we're going to cool the burn tissue. So for thermal burns, we're going to use room temperature, preferably sterile water, for about 3 to 5 minutes. We're not going to use cold water on these patients. Room temperature water will be just fine. We're not going to use ice on the skin, because that can even cause further tissue damage. And if cooling was done in the pre-hospital setting, we're going to remove any kind of wet clothing, blankets, or dressings and provide clean, dry coverings. And we want to make sure that those are sterile for the patient. So sterile gauze on the patient to reduce the infection rate. We're going to be mindful during cooling of the burn to not worsen or cause hypothermia, so that we're going to cool the patient down and then immediately consider their thermic status. Okay, so maintenance of body temperature is crucial in patients with burns since they have lost their protective skin covering. We want to use that sterile or clean sheet or blankets to cover for both warmth and limit pain from air currents on exposed skin. So the air can cause a lot of pain for these patients. And then as far as G goes, that's our GIT resuscitation adjuncts or gadgets, however you want to call that. We're going to do some laboratory studies. We're going to anticipate that the patient will have an arterial blood gas and keep a good note of their oxygen content, their carbon dioxide levels, or end-tidal CO2 monitoring is great for that, and they're going to check the carboxyhemoglobin there. As far as monitoring goes, we're going to continuously monitor these guys on the cardiac monitor. We're going to note any dysrhythmias for patients, especially with electrical burns. They can have some rhythm issues. We're going to insert a naso or orogastric tube if the person has been intubated, or if the patient has burns over greater than 20% of their body, then we're going to consider that because of the high probability of gastric distension, nausea, and vomiting. As far as oxygen saturation and capnography go, with any suspicion of carbon monoxide exposure, we are going to throw that pulse oximeter out the window because it's not going to be reliable. It detects carbon monoxide just like it detects our oxygen, so it will show us a very false high of what's actually going on status-wise, which is why an arterial blood gas is going to be so important for these people. Then we're going to assess for the pain and manage that pain. Burns can be very, very, very painful. Pain management is a super high priority. Even when the patient's intubated, we want to give them a great amount of pain medication. We should know that during a burn, the patient becomes hypermetabolic, and so we want to make sure that the pain medication is given quite frequently because it will metabolize out of the body a lot faster than it would otherwise. As far as reevaluation goes, we are going to consider taking this burn patient to a burn trauma center. I had mentioned earlier that the burns trauma center, there's only one in Washington State, a couple in Oregon. So we will no doubt be sending these people out, and I will give you a table here in the future that will show you how we're going to or what the criteria is for sending these patients out, and if we could potentially keep them. More than likely they're going to be sent out. We need to know H, history, and head-to-toe assessment. As far as history goes, we need to know the following. Was it a structural fire? Where was the fire? Was there a fall that resulted as, part of the escape? Was there a blast that occurred? And then as far as head-to-toe assessment, we're going to look at the depth of the burn. And we need to understand that the depth of the burn may not be fully realized until the wound has been debrided, just like in the case of some of our pressure ulcers that we get. We can't really tell the depth until we look at the debridement over there. Okay, continuing on with the head-to-toe assessment. This right here is an example of the rule of nines, as you can see here, and I won't expect you guys to memorize this, but we'll play around with it a little bit. So we'll look at our adult population first. As you can see here, almost everything is broken up into some subset of 9. So the anterior leg would be 9%. The posterior leg would be another 9%. So if an entire leg is affected, then we're going to consider that 18% of the total body surface area that was burned. The perineal area is about 1%. Anterior arm 4.5, anterior head 4.5. So if you have a full scalp or head burn, we'll consider that to be 9%. So as you can see, rule of nines here. This is Lund-Browder, which gets us quite a bit more technical. So, as you can see here, this only calculates like the trunk area where the rule of nines was about 18%. This trunk area is right at 13%. So this gives you a more detailed description of how to calculate this the total burn surface area, total body surface area of a patient. And really how it goes in the emergency department is you kind of get three people's opinions and then sort of average those out or come to a consensus based on multiple opinions. Usually it's not one person doing this. Continuing on with the head to toe assessment, our circumferential burns, we need to, determine the location of the burn. Then once again, is it circumferential? We have further interventions that need to happen if it is a burn in the perineum. And these are highly susceptible to an infection. We need to get them on the proper antibiotics. And then hands and feet, they have, a lot smaller vasculature, so there can be some perfusion issues with this. They'll need lots of intense rehab, and they can have some lifelong consequences of that. As far as our reevaluation adjuncts, we want to pose, just like in the case of our compartment syndrome, we want to position the extremity at the level of the heart, not above the level of the heart. And this promotes that circulation to assist in reduction of edema there. We're going to also administer a tetanus prophylaxis for this patient, and we're going to provide psychosocial support, consider referral for psychological counseling for both the patient and family. These, like I said, can be quite devastating. Then we're going to do some ongoing labs, repeat those ABGs. We're going to continuously check that glucose for our pediatric patient, and then we might consider some hyperbaric oxygen therapy, especially if the patient has had some carbon monoxide issues. Okay, let's take a look at electrical burns. Our interventions for this is going to be a cervical spinal immobilization. Oftentimes these electrical burns can create kind of a pressure or a blast type explosion on the patient. So they might have a wound based on this pressure wave that comes back and makes them fall. So let's consider their cervical spine and immobilize that as needed. We're going to maintain their fluids until their output is about 0.5 to 1 per kilogram per hour. With our electrical burns, they have a higher risk of having a rhabdomyolysis, and so we need to treat this myoglobin with extra fluids and really consider if they have rhabdo. We want to take a look at their urine, right? And if it's kind of that dark red or brown, then we'll consider that. We might need to splint extremities. These patients are also going to get a tetanus immunization, and they will need an ECG with continuous monitoring. Lightning strike burns, these can happen either directly or non-directly, so you can catch the whole weight of the lightning strike, or it can happen nearby, which can cause an issue. I can only guess that this person wearing a golf glove was just like tempting a lightning strike with them carrying a golf club. So shame on them. This is a high but brief direct current injury or energy. And VFib can occur, but it often occurs early on this patient. So we need to consider defibrillating this patient as quickly as possible if it allows. These guys are also at high risk for rhabdomyolysis, so we need to constantly look at that urinary output for them. And they are at risk for compartment syndrome as well, so we need to be looking for those 6 Ps. Remember that? Okay, so our chemical burns. First and foremost, with the chemical burns, we are going to consider the safety of the trauma team and make sure that we are not cross-contaminating or cross-exposing the trauma team to any of these chemical burns. So we're going to use PPE with these patients really a lot. So patient decontamination, most of any dry chemicals can be decontaminated by removal of the patient's clothing. So we need to do some careful removing of the patient's clothing and jewelry, and we're going to use caution not to scatter any of the stimulus or causative agent. So very, very carefully. Then we want to lightly brush any remaining dry chemical away. If there's any other leftover dry chemical, we are going to dilute and flush with liberal amounts of water. As far as history is concerned, we want to know what kind of chemical, was it an acid or alkali, was involved, what was the concentration and volume of the chemical, and what was the length and route of exposure. Nursing care for our chemical burn patient. We need to evaluate whether it was for inhalation or any aspiration rate, and then consider oxygenation and ventilation for the patient that might have inhaled or aspirated. Then we are going to irrigate the skin until the pH is normal. Normal pH of skin is around 5.3. In this case, we will use warmed tap water, not too hot. We're going to debride any kind of blisters and determine the type of chemical. So tar or asphalt, remember that's an alkali. We're going to stop the burning process, and then we're going to cool with water, and then we're going to remove that with petroleum jelly. Phenols. These are acidic forms of alcohol, and they're poorly soluble in water. They're found in a majority of household disinfectants and chemical solvents. We will want to use PEG solution for these guys. It's going to increase the solubility of the phenols, and it'll promote that decontamination there. Phenol burns can cause a thick eschar to the affected area if they're not removed quickly. Hydrofluoric acid, we are going to irrigate that wound for at least 30 minutes. And then our reevaluation, post-resuscitation, and definitive care. In our next slide, we'll talk about going over the criteria for transferring to the burn center. And the American Burn Association wants to remind everybody that we should not delay transport or debride burns. So we won't be spending too much time debriding the burn. We will hurry up and get those patients transported. And who qualifies for a burn transfer or burn center transfer? This is a patient with partial thickness burns greater than 10% of the body surface area. Any burns involving the face, hands, feet, genitalia, perineum, or major joints is going to be a consideration for leaving. Any full thickness or third-degree burns. Electrical burns, chemical burns, inhalation injuries, and complex comorbidities such as diabetes or heart disease, or any concomitant trauma with a high risk of morbidity or mortality from that burn. Any pediatric patient who is not in a dedicated pediatric facility, so all the peds patients locally will need to be transferred to a burn center, or if there's any special social, emotional, or rehabilitative intervention requirements. Those all qualify for going into a burn unit. As far as nutritional requirements for these patients, because they're in such a hypermetabolic state, these burn patients are going to require additional calories. So we're going to start internal feeding as soon as possible, and that generally happens within the first 6 hours after the burn. We want to try our best to maintain that patient at anywhere 5 to 10% of their pre-burn weight. We're going to minimize glucose fluctuations, so keep a tight control over those and monitor them. And we're going to give this patient lots of protein, lots of carb, and somewhere around 30% of fat. So lots of nutritional support for our burn patients. And that is it. Thank you, guys.